It's a great pleasure today to introduce my friend and former colleague at Vanderbilt University, Dr. Waitman. In terms of background, let me explain a little bit your background, Ras. He studied electrical engineering at Washington University in Missouri. Then he went to the Air Force, where he became an Air Force hospital administrator. He assured me that he never killed anyone except for bad medical practices at the hospital. After his military service, he went to Vanderbilt and got his PhD, specializing in data mining techniques, if I recall correctly. And then he joined the Vanderbilt Department of Biomedical Informatics as a faculty. Ras very quickly realized the importance of operational relevance of informatics. And instead of just focusing on academic work, he started putting more and more emphasis on operational work. And he got involved with the Vanderbilt's provider order entry system and other clinical information systems, and quickly rose to the level of heading the Vanderbilt CPOE. For those of you who understand the stature of the Vanderbilt CPOE in the informatics world, you understand this is a very big deal. Subsequently, he was recruited by Kansas University, and he became the director of the medical informatics, and I believe the CTSA Informatics Core. And then in his latest move up, he became the Assistant Vice Chancellor for Enterprise Analytics for the university. And I think that the work that he has been doing there in terms of integrating data and leading the way toward advanced analytics to improve healthcare is absolutely groundbreaking. And I think that it's going to be superbly interesting to listen to what you have to present today, Ras. So thank you very much for coming, especially given the snowstorm and all the horrible weather. And we are very eager to listen to your talk.
Well, thank you. All right, so there are many things I could talk about, and I'll try not to bore you with too many things, but I'm going to kind of give you a tour, I hope, of one area I think that may be most applicable to NYU. I really have immense respect for NYU, Constantine, and the team, and the amazing analytics that are done here. We are a pale shadow, or not even attempting to be a shadow yet, of what's accomplished here. But we have done some interesting work, I think, on data integration. And really, I think I know Tom from Vanderbilt days, comes from Cornell, of how you begin to serve more the general clinical translational research audience, and then how can you look for win-wins where that can also serve biomedical informatics research. So what I'm going to do as an outline is give people what I call a fishing story, which really, how many people are clinicians in the audience? Anybody? Okay. How many people would consider themselves a biomedical informatician of some sort? Okay. So what you find a lot of times is there's a big gulf between an informatician and a clinical faculty member who may be just beginning to be interested in research. So you got to explain to people, what is this informatics thing? And then I'm going to make some observations about coming to Kansas 3 years ago and starting a program and figuring out where to put my foot down and to try to put a stake in the ground to get some things done. I'll briefly then describe, kind of as a detour, some other activities going on in Kansas City which might be interesting to people in New York. And then I'll close with a little bit of talk about where I see the steps for us in collaborating with others lie. And then I hope I reserve enough time, since I think we have an hour and a half, to just sit down and do some demonstrations and maybe answer some questions from the field on the data we have in Kansas. So now pretend you're the clinical researcher in Kansas. So what I try to tell people shortly is biomedical informatics can help people's research, which is oftentimes an unproven hypothesis. And fundamentally, at the easiest level, we've got tools and expertise that help you manage data and convert it into information. When people think of entering and managing data, they think often we try to tell them about REDCap. Do people here use REDCap at all? Okay. And then when it comes to getting data, we have a project we call HERON, based upon I2B2 from partners. That's really a way to go fishing for data. And then we tell them we have biweekly meetings, and they happen in the library. And then what I show people is everybody's a fisherman in research, okay? Does anybody here fish at all? Okay. So this is a place in Missouri that's close to Kansas City. And you want more than just one type of fish to answer your question. You may want, it's not just good enough to have the diagnosis information, you need to know what the treatments are and the observations. So if you go to this place, Bennett Springs, there are fish, they're all over the place, look at them all. How did they get so many fish? Well, Bennett Springs is a hatchery, so it's got this natural spring that puts out millions of fresh water, but the reason they have so many fish is because they're stocking them with trout. So that's the first goal of informatics, is to build a hatchery from our perspective at Kansas. Our secondary goal is when you need help fishing, because it's sometimes hard to land a fish, you need a guide, and we're there to help people land fish. And then people you often work with are, say, biostatisticians, like a sushi chef, to prep your fish, and everybody wants a tasty publication. So that's kind of, at a simplistic level, what we're trying to tell people about informatics. So the nightmare scenario is everything looks great, but you can't catch anything. So the analogy for clinical researchers is often, I entered everything in Excel, but darn it, I lost the spreadsheet. Or I missorted the fields. Or I've got this student who I want to do certain things, but they shouldn't be able to look at identified data. Or the flip side, on the fishing side, is here I am, I'm a clinician, I spend all day entering data in the EMR and I get nothing in return to help me gain insight into my patient population or into global patient populations. So if you're willing to enter data, aka buy fish and stock them, REDCap's a great tool for that. I won't go into too much detail. People know about REDCap. It's got case report forms, it's got surveys like SurveyMonkey, but it's really tailored to clinical research. We also have a Velo system, which is another alternative specifically for cancer research that does NCI reporting, adverse event reporting. And what we tell people is, and our model may not be perfect in terms of how we engage the customer, but REDCap will take a multi-tiered model. If you want to use REDCap, you can do it all yourself and we'll maintain the technical integrity of the system, but you're responsible for your data dictionary and data entry and integrity. So essentially that's the analogy of you've got to feed and talk to your fish. And we can do a middle model, which we've done for people, where we build their database in REDCap for them. The other model, so we tell people, again, REDCap, think of it like we give you a fish tank. We may bring in a different submarine every once in a while to spiffy it up by upgrading the system, but it's your fish tank. Velos is more of a system where it's like an aquarium. You're working with us to manage your trial. And Biostats typically is helping do the analysis. So fish tanks are fun. Does anybody have a fish tank in the audience? Okay, not many or none. But really, you know, that's neat, but it's not as much fun as getting something for free, which is essentially what you're doing oftentimes when you go fishing. So HERON is our system for being a managed fishery. And so to go fishing, it's a lot like real fishing. You can't go fishing without a license, right? You can, you might get busted by the Department of Fish and Wildlife and you go to jail or face a fine. So the first step, and this is a step that I think may be often overlooked in the informatics literature, is how do I get business agreements with the clinical organizations that are covered entities under HIPAA to trust me, a research institution, with their data. So Kansas, I think, is different possibly than Cornell and NYU in that the university function, the medical center, is a separate corporate entity and it's part of the state of Kansas. The hospital authority is a separate nonprofit, and every clinic foundation, even though it's headed by a department chair in the university, that clinic foundation is yet another separate nonprofit. So we had to set up policies for us to begin to aggregate data. And then when that's in place, we've implemented essentially a tool, I2B2, that allows people to go fishing. And then over time, our goal as card-carrying informaticians is to begin to try to let people know what they're catching and align the data with national standards. But fundamentally, the underlying goal is it's only as good as the different types of data you maintain. So this is a front end on top of I2B2 that really guides people through. So some key features are you sign on using the exact same thing you sign on. So nobody has to remember an extra password. And then from an accountability standpoint, we don't have to worry about the fact that we maintain passwords and usernames. It's maintained by the overall enterprise. We do a real-time check to make sure people are current on their training. They sign system access agreements that are reviewed. And then they have the ability as faculty to sponsor. Now, if you're faculty and you've done all three of those, you can go fishing right away. There's no other barrier. If you want to sponsor a student or a staff, you've got an option to do that. And then when you're ready to go get data, as long as you're happy with de-identified data, you can actually request data without an IRB protocol. Now, if you want identified data, you can do that as well using the same tool. You just need to attach your IRB protocol. But that way, the governance committee of the hospital, the clinics, and the university can review how this resource is being used. Because that's a barrier oftentimes is convincing the operational entities that clinical research is going to be good. This is why we're an academic medical center, and we want to be a partnership with the operational entities, the clinical entities, and the researchers. We have ours set up where it's accessible only via VPN, and hopefully the VPN on my machine will hold up for our demo. So has anybody ever seen I2B2 before? Okay, so ma'am, where are you at?
I'm in the division of informatics here.
Okay.
Med Center, but working with the CTSA Informatics.
Okay. So this is the same I2B2. We're on a fairly recent release, 1.607, so that's another thing. It gets better every year. I'll say that both about REDCap and I2B2. One of the reasons coming to Kansas with a very small team, I wanted to use other people's stuff is if I can make a open community work, then I gain the benefit of the fact that every year Paul Harris introduces all these great features for REDCap that I don't have to develop. Same thing with I2B2. Even though I'm not a big fan of Java, if Mike Mendez and Sean Murphy add a lot of great new features, I don't have to develop that stuff. So what we've focused a lot on is how do we take those two tools, try not to alter them too much, but build around the edges and fill them up and integrate them in a proper way. So this is just showing with I2B2, you navigate folders to select concepts, you drag them in. So I drug in a diabetes concept. I have included, at KU, we have a subset of about 15,000 patients who've consented to be contacted for research. So in this environment, nobody knows who they are, but you can do a search to say who's got diabetes, who's willing to be contacted for a potential prospective trial, and who's had a hemoglobin A1C drawn that's greater than 7.5, so uncontrolled. Then you can run your query, and our goal is to get this down to where when the query runs, it's fairly responsive, because everybody initially is amazed that they can get access to data, and then very quickly they're frustrated when it takes longer than 20 seconds. So has anybody heard of Louis C.K., the comedian? Right, okay, he's got a routine on, I think it was on Letterman or Leno. Everything's amazing, but nobody's happy. So everybody's amazed, I can get Wi-Fi on a plane, and then it wigs out for 2 seconds, to, oh, this sucks, So that's kind of what informatics is all about. You're trying to give people a new tool, and for a brief moment, they're like, this is amazing, this is transforming my business. But then if it takes longer than a minute, they're like, oh, it's broken. So that's one thing when you try to build real-time tools. And that's where a lot of the systems engineering comes in, is try to figure out how you can make a team and a system that's responsive. So the next step you can go at with I2B2, and this is off-the-shelf I2B2, is you can begin to visualize timelines. Now, many people who use I2B2, they turn it on and only let people count because they're concerned about possible re-identification. Fortunately, at Kansas, we've worked with the oversight committees to say, since it's all de-identified, everybody's signed a system access agreement, we're comfortable letting people visualize what's happening with a patient. So I don't know if hopefully it shows up okay, but what you're basically seeing is for each of those patients in that cohort, you can see characteristics such as when was diabetes recorded as an observation, as a diagnosis, when were they entering the Frontiers Participant Registry, when have they had hemoglobin A1C recorded, and also I've included other variables. So have they had a glucose recorded, and do we have body mass index? Because maybe we may want to do a sub-analysis of obesity. Okay? So in closing to the general audience is everybody has the goal. They want to land the big fish and get that JAMA article, but you don't want to let them get bit, okay? So as informaticians, our goal is to make the impossible possible with, hopefully, is I'm trying to do self-service tools, and that's why our work is interesting, is how do we do this in a way that helps them not get bit? So with that, I want to just jump into more of a high-level overview of me coming to Kansas from Vanderbilt and just making observations starting a new division. Constantine can probably testify, as many around the country, that the CTSA grants really were a impetus for many institutions to seek informaticians. And the call has changed slightly. That may not be quite the same scenario for the new RFA. And I was leaving Vanderbilt after having been there for a very long time as both a grad student and a faculty member. And some key observations I just have about Vanderbilt is that Bill Stead really built it to be knowledge information focused and really break away informatics on top of what is traditionally transactional IT systems. So some key examples were CPOE, where we really had an order entry system when it was in its best of times, could actually help influence decision making, and physicians did not hate the system. And that was a major accomplishment, and it was an interesting balancing act. And then again, take data out of vendor systems, repurpose it to the enterprise. Vanderbilt, unlike Kansas, was a place where academia and operational were heavily integrated into the same organization, and as Constantine said, it created a lab where informatics could occur that had real consequences. And as I was leaving, it was growing much more on the bioinformatics and personalized medicine side. So at Vanderbilt, again, a consolidated leadership, unified informatics. The downside may be it has a long legacy of build versus buy mix of legacy systems, internal and corporate systems, that leads to a lot of complexity. Has a great consolidated home for informatics, and data sharing was not that big of an issue. Kansas is much more like the real world. I hate to say it. I mean, it's the real world is not so homogeneous. You've got to figure out, how can I work with vendor systems and then add on informatics? But if we can figure out how to do that, it will scale. And then data sharing fundamentally involves partnerships and trust with different organizations. So my initial vision for KU Informatics was very simple, and that was, I want to go at the heart of the matter. So other people may dance around the issue, but I wanted to go right after health and clinical data and make sure we can be trusted to manage that data, which then in turn will help us learn about care delivery, and it will be used by other researchers for a whole variety of purposes. And then as we develop strong relationships first at our hospital, that might then open up the ability to work broader with the state. Because that may be an advantage of Kansas over New York, in that Kansas City's medical center, University of Kansas Medical Center, has a hospital campus and medical center in Kansas City that's right on the state line. So if you've never been to Kansas City, it's really Kansas and Missouri. But then we have a satellite part of the same organization. We have 3 medical schools. We have Kansas City, a tiny campus in Salina, and another in Wichita. So as an organization, as we mature in informatics, we have a greater ability potentially to work broadly across the whole state, because we're the only medical school in the whole state of Kansas. But I knew that's going to take time. You got to start first in your own backyard, which is the hospital. So this is just, the initial thought was, let's get a data sharing agreement. And I thought, we've got to get this done before we submit the CTSA grant or we're sunk. And develop an agreement, an oversight, figure out and understand where the hospital and the clinics are going with their IT systems, and then begin to engage the research community and build out systems. So that's basically where we started. So we started again with kind of building an idea of building a warehouse around I2B2. I'm going to skip largely over this slide, but everybody needs one of these slides in an informatics presentation. And what this is basically showing you is, has anybody been involved in a CTSA grant submission? Okay. If you were involved in that, I quickly realized it's an anti-grant. So some grants, you put a grant in where you propose, I am so unique that you've got to fund me because I'm so profoundly unique. Well, the CTSA, you want to be a little bit unique, but you also want to kind of cover the bases of what they're expecting you to cover to facilitate research. So everybody should have a researcher portal that's going to let people access resources. And everybody should have a clinical data warehousing kind of approach. And everybody has to figure out how to connect to T1 basic research. And you may also want to connect to T2 research. So this is just a picture showing that our HERON project is fundamental to integrating both EPIC, which is our EMR data, IDX billing data, and then also making inroads into biological specimen data that will facilitate T1 research. And over time, we want to begin to harvest out of the EMR what type of decision support is occurring. And then long term, we want to figure out where can we integrate data from national or statewide data resources. So I'm mainly going to talk a little bit about HERON, because I actually want to demo some of it, because I think that may be interesting to the NYU community. One thing to note, this may be a little, well, this is an informatics audience. This is okay. This is kind of just a high-level technical schematic of what's going on. And what you're seeing is that we get data from participating organizations in however they'll give it to us that hurts them the least. So in the case of EPIC, we say just give us a backup dump of the whole Clarity database. In the case of the GE IDX system, you already have a data mart flat file copy of your billing codes and your diagnoses. Great, just give it to us. You have a tumor registrar who updates tumor data to the state in a NACER format. Great, give us that file. So we take those files and we put them on an identified server that only our team and information security has access to. We then extract, transform, and load it into a schema that's I2B2 compatible, but nobody accesses. And then we de-identify it to put it into the I2B2 instance that the clinical researcher accesses, and our team. So a key take-home for people as they interact with this system that we've tried to tell people over time is it evolves every month. So every month at a minimum, we update the content, so you get more cases. But also every month, and on that note, we've taken an approach of we just rebuild it every month. We don't try to do real-time HL7 interfaces because I figured if I can do it once a month reliably, that's better than something where I have to monitor a lot of feeds, and it's been pretty effective. And what it also lets us do is we can have one database we're building while the other one is being used. So I think of it as cakes. Everybody's consuming one. We're then preparing the next one, and then when we're sure it's ready to be served up, we can serve it up and switch over people. So that way we don't have any big downtimes. The other things to note, so we get the files, we get these extracts, and then we've written most of our work in SQL, just straight vanilla SQL. We're trying to be as vanilla as possible. We use Oracle for our database, but we've got minimal Oracle, and then the process is wrapped in a language called Python. And we've been very successful. 20 months in a row we've released every month, so that's pretty neat. So again, you get fresh data every month, you get new types of data. So I'll show you like family history we brought in January. And then you get new functionality. So I2B2 delivers new functionality such as you can find out who had this and this happen, not just in their life, but during the same clinical encounter. Okay, and so on that note, just as a more technical point to point out to people is Cache MUMPS underlying EPIC is actually a hierarchical database, circa 1969 or 8. In terms of its architecture, a lot of systems like Cerner, GEIDX may be in a relational database. If you're not familiar with I2B2, what is somewhat interesting about it, to get your head around, is it's very simple. It really has only 5 tables. So if you were to look at EPIC, for example, there are thousands and hundreds of master files and hierarchical concepts that then they turn into what they call clarity, which is roughly 6,000 to 10,000 tables. Huge amounts of data that if you wanted to figure out how to get stuff out of that, it's a lot of work. And what we're doing is we're taking all that complexity along with other data sources and putting it in one representation. And what's powerful about that is then you can build tools that interact with that one representation that then scale. So you don't have to have separate processes to deal with medications differently than you deal with lab results. Another interesting concept is you have everything is a fact at a given point in time about a concept, but the concept can have a path. So it can have a hierarchy or a primitive ontology to how these concepts are organized. And that's a key note we took home, which was when we got into this, and probably everybody who uses it had the same observation, but I thought we were kind of clever. And that was, we took a lazy approach. So when you look at a lot of informatics problems, some people take an approach where they want to be pure and have it mapped to the national standard up front, right? Because they want to be good card-carrying informaticians and use LOINC or whatever their favorite SNOMED CT or whatever, but then that's bad, okay. We said we won't bother with that. What we'll do is we'll load it with whatever they call it at KU Hospital in their EPIC build. Because what you can do in I2B2 is you can then link one ontology to another. You don't have to reload the data. You can just build a different ontology. So this is an example of the local term for potassium, serum potassium was 2002, and then you can just map it to the LOINC concept. And what's interesting about that is this is an example where I'm showing you where we've got the two side by side under the same potassium folder, but you could really build different ontologies side by side. So if you had an organization of data that you thought made sense to nurses and you had a different one that made sense to orthopedic surgeons, you could build completely different ontologies sitting on top of the same data and let people browse them in however they felt it was best. So I think there's actually probably some research in figuring out what's really a usable organization for people using data, and you could actually study and see, what do people prefer. So that's a key thing. The other key thing I'll just say high level, and I'll run through some screens, is I feel for us to be successful, and it may be my engineering bent, but we found managing it as more of a software engineering project has been valuable to get on the road where we can deliver every month. So every month, we're tracking milestones using a tool called Track that lets us kind of define what are we going to achieve this month. That then decomposes into tickets that people are working on that they can bounce back and forth. A ticket will then translate into committing code to a version control repository, which then people can browse and see that, oh, this is what we changed this month. So if we ever have any problems, you can go back and see exactly what changed. And then what we do as well is when we've prepared that release and we've released it, we also write a blog article that kind of gives the customers an overview of what's going on. So what you see here is at a high level, the big take home this month was we released family history and social history, and we also added some encounter vitals that weren't there before. And then we update for everybody, here's how the number of facts are growing. So this month, back in January, was also when we broke 1 billion facts. And we also remind people, every data source has its own life cycle. So our billing data, just in general, our high-level demographics goes back to the 80s. Our cancer registry goes all the way back to the 1950s. But then we may have another data source like the basic O2, what they call O2 or EPIC. That went live in November of 2007. So when you look at combining these data sources, you always have to keep in mind, well, what was the lifespan of this data source? So again, the goal is really, how do you create a rich picture of the phenotype? So if I had these volunteers in a registry, how many of them do I also have medication data on and I also have lab results on? So this is just a picture from the summer showing that at that time, the majority of patients in the registry, we had all three kind of together. This, though, again, is technically, it works, but it does take you time to manage this. So, for example, we use Fusion IO fast storage cards that really help with performance. But even then, we had a problem where we upgraded the system. The Oracle tuning went out of whack, and the query time just went through the roof up to like average of 800 seconds. So we're now, as we've dealt with this, trying to make sure we're much more reliable in terms of continually monitoring the performance characteristics of the database. We have regular tests we run. So that's a big credit to a lot of the people on the team. This is just another thing we've put in the system that we use, but also encourage customers to look at, which is a button for who's using the system so they can see who are the other individuals in the institution using it. Are there any colleagues there you can bounce ideas off of? We've made training videos. We ask people to request consults with us. We've got feedback buttons. If they don't like what they see, they can let us know. And then that also has a flip side, which is part of working with the hospital and clinic. And that is we have a coordinator who works with the customers, but also works with the hospitals just to audit. Are there any small queries where someone is trying to define a small set of people? Because the big risk you have is they're trying to re-identify their neighbor in the database. So we monitor that activity as well. And we also try to promote the fact that a use that I had not conceived of is very useful, which is just use this system when you put in a grant to see how many people you have. That you can say, yeah, I can run this center or get this grant because look, we used our data warehouse, we've got this many people, or I can have enough patients to do a prospective trial. The other area where it's useful is as we have a biospecimen repository linked, it can really characterize their biospecimens with the phenotype from the EMR. Another point to bring up, I will quickly cover this, and that is we de-identify our database according to HIPAA. And what's good about that is, as our IRB said, if we took out all 18 identifiers, it would no longer be human subjects research. So that takes out a lot of the barriers people have to accessing this type of resource. The biggest one that, now this is our interpretation, that you have to comply with is you can't report a date more frequent than a year. So what we do is we take every person's birthday and we move it back from up to 365 days in the past. And then every other fact about them gets shifted the same amount. So in general, what that means as a downside is if you want to do a seasonal study, so when is RSV season striking the pediatric population, or you have a hypothesis that it's a bad idea to get sick in July when new house staff come on service, you can't do it in the de-identified data. You'd have to get IRB approval first, and then we can go back and get you identifiers. But you can still answer a lot of questions. We ask, though, that the customer treats the data they receive as a limited data set from a systems perspective, that they don't treat it as non-human data because there always is a risk of re-identification as smart people like Brad Mallon at Vanderbilt try to reverse engineer data. And the other thing we haven't done yet is we have not done any incorporation of free text notes using de-identification algorithms. we've found there's so much rich data in structured data, we're going to go after that first, and then later as the team grows, we might get into trying to adopt some good NLP techniques or scrubbing algorithms. Okay, does that make sense to people? Okay. So then I just want to talk a little bit about, so we submitted the CTSA grant in the summer, I guess it was September 2010. It was awarded in 11. That was great. I had a job at least for a little while longer in Kansas. And then we knew, though, the next big objective for the university was they wanted to become an NCI-designated cancer center. And so we thought, Matt Mayo, the chair, and I of Biostats, what could we do that's going to distinguish us? Because we want to show that a lot of places that have had a cancer center for a long time, it lives in isolation from the CTSA. So we thought HERON was a nice environment to show that we were taking a resource initially created for the CTSA, and we were going to target some specific things that would show we are also trying to rebuild this resource to benefit the cancer population. So some targeted areas we went after were the tumor registry. Is this great data in Kansas that goes back forever? Let's bring that in side by side with the electronic medical record. Let's bring in that biospecimen repository, which while it may not have a lot of samples, at least we can show where we're going. And then another component I won't talk about is we wanted to upgrade their system from an Access database to a vendor-based system. And then we also thought we will bring in REDCap into I2B2 so that if you want to annotate a patient population in a registry, you can do that in REDCap, but you don't have to annotate everything because if it's in the EMR, you got it there. And then we also did a demonstration of integrating the statistical package R in the environment so that you could begin to do preliminary analysis. So that's basically the steps we saw. And then a key hurdle that wasn't a hurdle. By the time we'd been working with the hospital, it was a joint good decision was then we opened up the ability of people to see line item level data, not just counting, because you need that to use statistical methods. So with that, this is a chart I kind of gave people to explain to them that currently when we started with let me explain the chart. The chart's basically showing you when you build a data repository, you have three approaches fundamentally to what data it could contain. You could load it with fully identified data. You could load it with a limited data set where you may scrub the names, but the timing is exactly right. Or you could load it with fully de-identified data per HIPAA. This is a fictitious risk scale, not based on reality at all, but mentally to yourself, as you can turn on I2B2 where it gives the customer the counts, but then it fudges them by plus or minus 3. So it's really trying to say there's no way you can re-identify people. So that's probably the most secure way. And then, of course, if you did that on a de-identified data set, that would be the safest from a risk perspective. And as you let people look at actual counts or view line item data or download data or view notes or then download notes, you're kind of upping the level of ability to look at the full clinical picture of the patient, but you're also upping your risk of disclosure. And so I use this picture to kind of explain to people, we were here and we wanted to let them just view line item data, and that's the next risk level we wanted to go after. And we pointed out to them that you already kind of let people have raw access to the EPIC chart to browse it. So if you're worried about re-identification, all these researchers can go right into the EMR. So a lot of times I think you'll face that as a tension, to try to say, hey, look, let's not be unrealistic about the burden of clinical research. If this back door is, they can just go browse the chart. Okay. So what that let us do is things like this. I could bring in the fact of who do we have a prostate sample on, who also is grade 1 or 2 based upon the cancer registry, and then get an answer back. So, that's a question that you couldn't answer with either data source by itself. And then this is kind of a high-level idealized workflow that I hope we'll just demo towards the end of you can browse and see what we have, you can define a cohort, and then we integrated a very simple statistical package of basically built a plug-in in I2B2 that could then generate a survival plot in R and bring it back. The other component, as I mentioned, was bringing in REDCap, which we haven't really had exploited yet, but I think it's really powerful because we want to especially work with the hospital to say instead of building a lot of little databases in Access, if you can just tag the patients in REDCap and have us bring it into HERON, you can tag the patients you're interested in following, but then link it to the rest. And I think that's going to be powerful over time. The other data set we've tackled lately is anybody familiar with the University Health Systems Consortium data? So that's all your academic medical centers participate in that. And we initially did not load the technical charges from the hospital because it was based upon an older system called Siemens SMS, and I did not want to write ETL for a system that's going to go away. And then we learned that the hospital does all its benchmarking around UHC, and that's a standard format, the CDB. So we wrote the code to pull that type of data out, and at first we were pulling it out just to get the diagnosis codes, and we realized it's got all this other great information like length of stay, DRGs, and then also kind of the benchmarked counts for AHRQ and other quality measures. So that's fun data. So this is just a couple charts showing you at a high level. This is an example of a REDCap, triple negative breast cancer registry, where BRCA status at our institution does not come back in as a discrete lab value. It's scanned in as a text report. So they had to abstract that data, but now they can combine that type of data with the whole rest of the EMR data. And then this is just showing you at a high level that the UHC data has admission information, quality measures from things like AHRQ, and then it also has all your different types of diagnosis data. So this is a chart just showing you in general, and it's reasonably up to date as of January, showing that EPIC is a key source for us. We've brought in a lot of information. There's some information we know we would like to harvest that we haven't harvested yet. And actually, we just harvested surgical history in February. And then we've brought in some data from the clinic's billing system. We brought in the biospecimens that a specimen's collected. And from the tumor registry, we have data like stage, grade, diagnosis, survival, and progression. We've brought in just, I think it's a good feature for outcomes research, but it has some practical implications for trials. We bring in the Social Security Death Index, so we know by social if somebody has passed. The most practical application we have of that right now is not as much for outcomes research, but when you're using HERON for prospective patient identification and you want to call people on the phone, it's bad form to call somebody if their loved one just passed, right? So that's a quick way to filter out that embarrassing conversation. We have the UHC data with technical information. We brought in REDCap, and we may look to bring in some of the clinical trial data to help us understand trial accrual. So what I look for in informatics, kind of as having built this team up then, is I would love to get involved in projects with my clinical collaborators where they help me validate that we have good data, but also help answer new clinical questions. So that may stretch how we model data, how we organize information. And so an example in the past that we published in AMIA at the conference was really we brought in flow sheet data, which I'll show you is actually most of the data we have. Nursing flow sheets are overwhelming. Nurses, physical therapists, respiratory therapists document voluminous amounts of data that many people forget about. And I don't know if it was dumb luck, but I just reflect at Vanderbilt, there was so much focus on natural language processing of physician text notes that they forgot, and I was responsible for implementing barcode MedAdmin and nursing flow sheet, that you had this rich amount of data of what the nurse is documenting in a structured manner every minute. So that's a huge resource. Presently, we're working with preventive medicine, the pharmacy, and the surgical or medical ICU to look at, we've brought in data about medications, not just that they were ordered, but when were they given on the medication administration record. And we want to do a project where we can kind of validate that we've loaded it correctly. And can it help us track things like, did they get the antibiotic in the ED in the right amount of time? That's kind of interesting because typically I2B2 has been used for more outpatient ambulatory research, and a lot of its tools are not tailored towards data down to the minute. So that's an area we're working on right now. And then we've also found it's useful, we've done some small projects or looks for people, so you can see things such as if people record DNR orders in their ambulatory setting, is that getting reflected into their inpatient code status? And then other areas we see working on are we've brought in things like smoking status, family history. Is that going to be useful to people? And so our mission is how do we get clinical researchers engaged in using this? Because if we load it and nobody uses it, data has the potential to rot. It could have been an error in how you loaded it, or you just aren't confident in it. So that's kind of the next phase of if you build it, will they come? Next, I want to go to kind of a little bit of a new area, but it relies on HERON, and that is one of the early successes that I had no idea about, because I was at Vanderbilt, but I did almost nothing with clinical trials, I'll be honest. I wasn't much of a clinical research person. And so the first success we actually had building I2B2 was we had a very small data set of the patients who had volunteered to be contacted for trials, and we had their billing codes, their ICD-9s, and their CPTs. And that was the first set of data I had. It was nice and small, and I could actually show people that, well, look, if we can load that into HERON I2B2, we can help you identify which patients you want to recruit. Because if you've got this registry of 8,000, 10,000, 20,000 people, and there's no way for you to filter it, it doesn't do you a lot of good. So that was initially built as a flag in the billing system that then was paper-based and got rekeyed into the billing system, and then we harvested it. And we want to move to a web-based method that isn't ready yet, but that's what we're trying to get done this year. So one, our CTSA is a regional CTSA throughout Kansas City, and we want to build a tool that benefits our partners at the Children's Hospital, St. Luke's, University of Missouri, Kansas City. And then also we see this as a way to help replace a lot of isolated patient registries. So the head of our IRB gets a lot of requests of, I want to do this registry, I want to create a database. I want to create a database. I want to create a database. I want to manage my study population. And if I can create a tool locally, and I appreciate Research Match nationally, but that doesn't do any good locally if you're trying to maintain a registry in New York City or Kansas City. You need a tool locally. So we want to build a local tool that can replace those type of Access and Excel spreadsheets. So we're calling it Pioneers. And it's going to be based on Drupal REDCap. And we want to use REDCap so that you as an investigator could define your pre-screening questions in a survey, have patients sign up to be a pioneer, but then they could actually pre-screen. Because what we've got with Frontiers is they get a piece of paper in the clinic and then they never get contacted because we don't have their email address. So if we can get people to move to the web, we can keep them engaged with social media about what's happening regionally with the CTSA, but then also some people come in and they know they want to help out with Alzheimer's. So wouldn't it be neat if we could have them sign up to be a pioneer and then pre-screen for like an Alzheimer's exercise study? So that's the idea of where we're going with that project. And as we go forward, if anybody's interested, when this gets live, we'd love to share it with other people. Okay. Interesting at all? Everybody with me so far? Okay. So the next thing is something is changing in Kansas City. And I realize I'm in the big city, New York, right? So everybody thinks here we are in Kansas City. Everybody's looking over there, swap wheat goods. And of course, Kansas City is not a town. We actually all live in houses with windmills. And it's wintertime. So I had to come here after harvesting my straw with my horse team. But actually, in Kansas City lately, we've built this amazing new performance arts center. It's unbelievable. And there's a strange occurrence in that there's a growth of cats in the neighborhood that are trying to compete as lolcats. And then women who normally look like that have become amazingly attractive. So what is going on, you might ask, right? I mean, it's amazing. Google is coming to Kansas City. Okay, has anybody heard of this? Google Fiber? Okay, what Google Fiber is, they selected across the whole country Kansas City, Kansas, and then very quickly thereafter Kansas City, Missouri, as the first community in the world to get gigabit bidirectional internet to your house. So you can do this. You can record 10 TV shows at the same time, and you'll use a Nexus 7 tablet as your remote control, and you can preview shows. It's unbelievable. And their only Google retail store that I know exists is basically 5 blocks away from the medical center. So we actually had a joint partnership with them where we demonstrated telenutrition as an example of what this could do for you. So that's really our responsibility as the medical center. We're going to have to figure out how we find something useful to do with this for health besides lolcats, 3D video games, and so forth. So we got a small NSF grant. There's an NSF activity called US Ignite that's trying to say how do we build next generation applications that are going to take advantage of high bandwidth to help get the US up ahead of Korea, and other places that have outgrown our bandwidth as a nation. So we've got a small grant to look at in-home monitoring to take care of not the patient but the caregiver of someone who has dementia. And we're working, whether we're successful with research, at least it's interesting multidisciplinary because us in informatics are working with our telehealth people, with the School of Engineering in Lawrence, and nursing and the Alzheimer's Center. And so this may not be, this is the closest we could think of today of high bandwidth. And what it is basically, we think really Wi-Fi webcams. Has anybody heard of Dropcam at all? Okay, you can Google it. You can buy a webcam for $150 that streams everything to the cloud. And now with high bandwidth, you could put these all over your house. And I have one, and with the current internet, it works pretty good, but if I'm at home trying to watch movies and stream the video up to the cloud, it runs a little slow. So it's like, has anybody heard the expression a nanny cam? Okay, it's basically that idea. And we want to see if you can use multiple cameras for health and figure out how does the patient's environment interact with a coaching team. That's really, the scientific contribution will be to see what portions of the NSF infrastructure like Genie racks might play a role in there. And to me, the more informatics challenge is, oftentimes in the past, this type of remote monitoring has been viewed as a very parochial activity in that the camera belongs to the provider. It's the healthcare provider putting this device in your home. Well, realistically, the pace at which this type of technology is happening is overwhelming. So, and as the age of people evolves, you know, people are going to be much more comfortable. Now, many people over 40 may not be, but people are getting very used to the fact that they almost have a digital persona or life. So what you really want to look at is how does the digital life interact with the provider community. So we'll be working to try to fill in that gap. And then we're also looking for other types of projects. We may look at, you know, when do you use Amazon cloud computing versus local resources. So we're involved in this type of research in Kansas City. It's really a neat opportunity with Google coming to town. And so this is the logo, if you didn't know, for Google Fiber. It's the rainbow-colored rabbit. Okay, so we're doing good on time. I want to keep at least 30 minutes or so for demo. This is my high-level view of medical informatics, so I'll get a little bit more into my interests and then also see how that aligns with building infrastructure. And so what I basically have here is a schematic of this is you, the patient, okay? And this represents your health or physiologic reserve after talking to trauma people. And in general, it's pretty darn good, and you never interact with the healthcare system. But sometimes an illness attacks it that gets so bad that you're willing to interact with a healthcare provider and sit in a waiting room. So when you look at it from a systems perspective, there's all kinds of factors that may go into that. You may be an environmental issue of working a lot of toxic sludge. You may have social behavioral issues or benefits like exercising a lot. You may have genetic markers, and you may have diet and drugs that influence that. And traditionally, there's really two systems going on in healthcare. There's the clinical delivery system, and then there's the administrative system that collects administrative billing type of information. And I am not totally up on this literature, but I would say most health services research has only had access to this type of data. So that would be an example of UHC data, standard data sets. And now what's happening is with the EMRs at the heart of it, you collect a lot more information. And so what this is just showing is you interact with the provider, they make observations, some of which will turn into outcomes, but they're never recorded, but some of them make it in as outcomes you can analyze. And then you may actually have observations about how people use the EMR. Then they may decide to do something, and they may enter that in a system, and you may have observations about was the decision support effective. And then that system may generate more data, such as ordering lab tests, or you may generate interventions, like ordering a drug, a procedure, or some type of unregulated change like a diet change. So the first hypothesis, broadly I'm interested in, or many in informatics are, is does the addition of all this clinical information, can that possibly benefit our understanding of knowledge about health? Whereas previously I was just analyzing claims data. The second hypothesis would be, is this actual EMR computer activity, is that benefiting the healthcare delivery process? So where we're starting to go as a team is really seeing, if I'm trying to work on these problems, I would like to figure out, can I reuse my HERON I2B2 tool environment and bring in some other very first step tools that let us do that type of insight within this environment. So what we're doing is, this is kind of in development, but we're basically creating a way, and it builds out of that demo for the NCI site visit of survival analysis, where you can generate data sets in I2B2 and then ship it out to R. And our studio server is a tool we're using for that, because then all the data never really gets passed to the investigator. It's still all, say, server side. And so I may have time for an example. We may just browse around a lot. But the goal would be, you know, can you look at observed versus expected mortality according to UHC, and could you begin to look and see if you incorporate other clinical variables, does that explain more or less of the variation? Haven't done anything with this yet, but that's kind of where we'd like to go. So we may start with kind of looking at the current UHC linear models, seeing if we can replicate those, and then going forward. So what I'll do now is we've got time for demo and questions, and I will start off with just a demo of some of these capabilities if you haven't seen it or if you can kind of get a feel for what we have, and then we'll take questions along the way, if that sounds good. And what I'll try to cover in general is just show you some of the features of newer I2B2, show you some of the existing features we have. There's a modifier concept in I2B2 which is really new and powerful as of about last year. And then we may get time to go over to the test system and look at the RStudio builder. So let me hop to the demo.
How much data cleanup is there before it goes to the HERON repository or the main repository?
Data cleanup? Well, it's basically every month it's scripted. So we have the DBA, database administrator, says, give us your new files. They get dropped on our server. And then our Python scripts pick it up, wrap it up, and then crunch it. So what we do is we don't do any human data cleanup. Our goal is to have it fully scripted so that, now we'll get error reports. Oh, there's an error, go back and look. So there's no hand curation. It's all scripted, but issues will arise. And they especially arise because we're not just doing the same thing over and over again, we're adding new features. So most of the time the error will arise because, say, the guy's harvesting social history, and it's the first time we've done this ETL, and we hit an edge case that we haven't run into before. And so we'll have to go back and refactor that. But once we get it done, you'll still have cases come up where a data source you've been loading for a while, you get a hiccup, and so we have to do that type of correction. Good question, Yin. And where you'll see it on us is we usually want to hit the 15th of the month for releasing the data, but sometimes it drags out for another 2 weeks because of these issues.
But in theory, you don't have a hard rule. So like if you have a BMI that's outside the range, you don't go ahead and scrub it. You just put it in there and let that.
That's a really good question. So we're not, unless it's something grossly off, like I think we have some data validation checks like, are you dead after you were born, things like that. But a lot of it, we don't make those types of decisions because one, we don't have the ability or time to know every single thing. So it is a little bit like fishing. Buyer beware, you may catch a fish, you got to inspect it in what you're getting. But we want to be very accurate about what we have is what's reflected in the EMR. Now that said, we have tickets that we look at where we notice things like, according to the tumor registry, the patient's dead, but according to the hospital EMR, they're alive. What's going on? And what we do in those cases is we feed that back to the EMR team to say, hey, what do you want to do here? We had a problem for a while where race and ethnicity were mixed up in the Epic database, and we had to say to them, hey, you're going to clean this up? And so we turned it off for a while, then they fixed it, and then we cleaned it up. So as we interact with it, we may discover these discrepancies, and we work with them to fix it. If they're an issue, we log them as a bug, and we'll actually list those down at the bottom of our web page. What we'll tell people is, beta disclaimer, various issues apply. So, we know there's some things going on here that are outstanding issues, which may be a bug with the system that we're still working on. Now, in fairness, do end users really look at that? Maybe not, but that is an attempt we make there. Okay, let me see, make sure this is still working. So this is production. Again, this would be, I'm logged in, it knows I'm faculty, it knows I'm trained, it knows I've signed my system access agreement. If I wanted to sign up a student to use the system, I can go use that. So we integrate with kind of our identity management system for the university. And then as a faculty member, I would just give a title of the research. I can expire their access. I'm sponsoring them, so I have to comply as the faculty member with how I sponsor them. I have to verify that Milan is employed by the university. If not, give an affiliation. If you're familiar with REDCap, this looks very familiar with REDCap. So we use REDCap for a lot of our administrative purposes to coordinate this type of data collection for managing the process. So actually the approval process is basically a REDCap survey that then has case report forms that each organization review. Okay. Again, who's using HERON? We're hopefully tracking to see that we're really excited. This is excitement to me. I have an assistant professor of urology using a clinical research tool. Wow. That's really cool. I mean, that now he may be completely drawing the wrong conclusions, but at least they're at the table, right? I'm joking. I know this guy. He was a fellow. But, you know, that's a big thing because you've given him a way to start to explore ideas without having to have an informatician as an intermediary. Tamara's our coordinator, so she's running a lot of queries because she fulfills every data request. But then other people are beginning to use it from around the campus. And then, you know, we're excited to see that over time, lately, since I started advertising some new features, you know, we're getting a fair amount of usage over the last couple months. Okay, so we'll drop into the tool. So if you're familiar with I2B2 or not, we have a lot of people who has never seen I2B2 in action. Show of hands. Okay, so this is the basic tool. These are those ontology folders. This is the place you build your query. These are workspaces, so most people only see their username and the shared folder, but I'm an administrator, so I see everybody. But this is where, essentially, as a user, you can save queries that when we upgrade it, they don't disappear. So I can save a list of kind of my cohorts that I'm interested in. And then these are all the previous queries that have run. As an administrator, I see everything, but most users only see their own queries. Okay, so if I wanted to do a query, I can use this tab to kind of tab the pane open all the way. And as I said, most of our facts are this flow sheet data. So I'll make a random query that's kind of fun to show. This is the cancer registry data. So I could do things like who has had lung cancer, and then I could incorporate something from the EMR, like social history. I think that was an example I discussed. And we could say, what's been their tobacco usage? So I might be interested in who has had never said they never smoked, but they've got lung cancer according to the validated tumor registry data. And now this is where the Louis C.K. routine comes in. Okay, great. That was simple, 2 seconds. So that's pretty neat. It's about half a terabyte of data and a billion facts. And then I could say I want to compare that with people who smoke more than a pack a day. So it knows packs per day is a numeric value. And so you would run that. And I'm going to run the query, and I'm going to save it. Normally you save it just as a count because you don't want to look at the data. But when you want to analyze the inline data, you say check the patient list box so it knows to save it as a set. So this is going to run. And there we go. So we've got 2 cohorts of people that might be interested in, because I might have a theory that even though they both have lung cancer, maybe they're different in some way. So I2B2, once we went beyond counting, we could begin to use analysis tools. And this is an analysis tool that comes out of the box with I2B2 that just lets you see basic demographic data about the patient. So I'm going to drag in the patient set of people who smoke, and I'm going to compare them with the people who never smoke. And I'm going to hit the button, and I'll learn, here's kind of the age distributions. And then, interestingly, the set number 1 are the smokers, and that's interesting. Most of them are more male than female. That makes sense, you know, that men smoke more than female, that they get lung cancer. We have some racial and ethnic data here. We also, for some reason, have religion, which with cancer could be an important factor. And then we have vital status. So, you know, you could see that it looks like the yes means you're deceased. So the people who have smoking history and lung cancer seem to maybe have a higher incidence of mortality. So now I'll show you something we're excited about, which is we built upon that demo we did for the NCI site visit, and we've developed a multi-cohort survival tool. So this is fun because what you can do is you can say, I can define a custom cohort that, you know, I can't get this on the NCI site. I can get actual smoking people at my institution, and I can compare them with people at my institution who've never smoked. And then I can say, I want to do a survival analysis. I want the entrance criteria to be when they got the lung cancer. Let me pop this open. And then what I can do is I can say, it looks much better when you have a bigger screen. I'm going to look at it. I want to look at death according to the tumor registrar. And I want the entrance criteria to be the last time the tumor registrar followed up on them. What's beautiful about this tool is, since we just developed this, is I can now look at things that have nothing to do with death. So if I wanted to look at another outcome, like I got this type of diagnosis and later on do I have this diagnosis, this tool can be used for that. But we'll just stick to the cancer example. So I'm going to run my analysis, and what's happening is the code has securely picked up the data into a data frame that it's shipped over to R, and then the R server has done its analysis and it spits back the picture. So this is the survival analysis in real time that's showing you that, you know, there is separation between these two cohorts. The never smokers, which were cohort 2, seem to have better survival than the smoking population. Now, would you want, I'm sorry, sir, yes?
Is it possible to access this resource programmatically, like through our environment or through the environment? Because you're using R and you're using SQL for most of the work. So instead of like downloading the data to my machine and then doing all the analysis, can I access it directly from my R environment?
Well, I'll point this out. Yes, yes. But in a way, we have you use, well, you're getting to another, my punchline is later on the test system, the R data builder. The hard part is figuring out what the cohort is, but I'll actually show you, I'll go ahead of time. We have it built in so that I could also, instead of having to have built that plugin, I can package up the data and ship it to R and then interact with it in an R data frame. Is that kind of what you're asking? We don't have much where programmatically, all within the R environment, you go hit the tables, simply because you'd then have to reinvent a lot of this code to build and define the cohort. So what we're thinking right now, the approach would be, you will still want to use the I2B2 tool to define your data set and quickly pick your variables. I think it's going to be much faster than you writing that code. But then once you define the data package you want, boom, drop it over to R, and now you can start analyzing it. And that's where using our Studio server, it's all server side. And I haven't made this available yet, but I'm going to not argue, but I'm going to work with the Data Governance Committee to say, since it's all server side, no one yet has taken any data that can be disclosed, could we let people use our Studio server for preliminary analysis prior to having to ask for a data set? So yes, good question. So here we would say, okay, there might be something here. People may get nervous that there's a p-value. Yes, yeah. Mm-hmm.
Yeah, that it's where it's coming from, who's collecting it, and that type of information, so that I can have a little more confidence that the values are true and that it's not.
It is what it is. That's what I tell people. It's the EMR, okay? So everybody will say that everybody else's stuff in the EMR is crap. They'll say the nurses can't document worth crap. The tumor registrar gets it wrong. This gets it wrong. All I can do technically is say we are taking it from the source and doing what we can with it. But what you're pointing out is part of this not letting people get bit. We have not yet mastered an elegant way of figuring out what the data fidelity is. The only way I simplistically know how to do that is to get people who are smart clinical researchers partnered up with people right in the hospital in the organizational improvement team to work on it together. Does that make, and I think we could do work over time to build scripting approaches to look for outliers. We actually have a ticket open where we did a little bit of look at data validity. We've got a long-standing ticket where we'd love to do a data dictionary across all lab values and look for, what's the distributions here? Are there any outliers that are cropping up? But we haven't had the time to build that out. But very good question. So it is fishing. I mean, and I'm embracing this disparaging comment of retrospective work that you're just fishing in a tongue-in-cheek way, because it is what you got, and it could be that this smoking status is not very reliably recorded. What's interesting is the other thing about this environment, or about the whole clinical research environment, that I will point out on this slide, that I just view this as mentally as a person is, when you think about this picture, as someone who was in biomedical engineering at one time and learned, was kind of into building ECG machines or stuff like that, is I kind of view every single system, whether it's a billing system, whether it's UHC, whether it's the EMR, whether it's vital signs, they're all like a vital sign. They're all like a physiological monitor. And so each of them may have different fidelity at different times for what you're observing. So just like you've got, you know, reference ranges on a lab test, in a way what you're asking is there are reference ranges in a way on the validity of a nursing document, an event versus a physician.
You and I published a paper on that, showing 5% of the blood glucose values from the blood glucose meter did not match what nurses entered by hand.
Yeah. So, you know, you're always going to face that. And what you're pointing out is really true is I think as people work with this, there's going to be different levels of quality of the research. You know, how good are they at knowing that? And that's why when I meet with people, I try to encourage them, work with a team. You know, not just a team from an informatics statistical standpoint, but work with people who really understand that data. And so far, I think the people who've really started to use this, they're either clinicians on that unit, so they'll look at the data and know, yeah, this jives. Or in the example I was giving about sepsis timing, you know, we're working with the pharmacy and the MICU director to say, does this data look right? You know, but that's a good question.
So this question really addresses the issue of the validity of the inputs to the aggregated data repository. But I have to tell you, first of all, just to clarify, I think this work is just extraordinarily important and well done. As a data analyst and as a computer modeler by trade, this represents both a dream and a nightmare.
Yes.
And I've never had one of those, you know, in actual life, but I think the metaphor here is applicable. Because on one hand, you have all of these wonderfully integrated and aggregated data and indexed and searchable and so on. On the other hand, if you look at, I mean, if you take this at face value, the example that you just gave, there is so much potential for wrong results. I mean, I would expect that 99.9% of user conclusions out of this kind of analytics is wrong.
Yep.
And the reason, and you're an analyst also, so but I want to say that, you know, you have the issues of missing values that are not random. You have the issues of selection bias of the population in the hospital versus the general. You have the issue of you are selecting only a small subset of variables, and that immediately has Simpson paradox type of effects. If you select a different subset, you will get completely different results. You have the issue of association versus causality. I mean, there's so many things that can go wrong, and there's nothing there to help the user to do a data design for the analysis versus just plugging in, you know, some inputs to an R, you know, function that does a chi-square or, you know, Kaplan-Meier or whatever. So how do you concretely, constructively going forward? Well, how are you going to address this data analytic, you know, opportunities for errors? And by the way, I highly appreciate your fishing expedition metaphor, because a lot of people are disparaging fishing expeditions, but they're forgetting that all fishermen, you know, in the history of fishing, they're going to fishing expeditions and they're getting back fish.
Yeah.
Okay, and that's exactly what we should be doing also.
So that's exactly right. So the example I was giving you of that R survival analysis plugin, or in another example, I could go through it on the test server. Let me just show you what that would look like while we're talking here. What I see, this is where I see the preliminary analysis as the next stage, because let me tell you what the contrast is. What's going to happen now is I've got all the data, right? And then what we can let people do, essentially, is, let's pick this population. They can go get the data. They can define the cohort they're interested in. And then they can ask us for the data, and then they can leave us. They go take the data and do whatever they want with it. They may work with a biomedical informatics analyst such as you, or they may work with a biostatistician, or they may work by themselves, or whoever they've defined on their team. And we have no control over, are they going to do the right type of analysis? So where I see these first steps of preliminary analysis is, it's our opportunity to say, can we start to build standardized methods for general categories of problems in clinical research that we could build as plugins or as R scripts that would help people get pointed in the right direction, but also help lead to quicker collaboration with data analysts. So I'm saying as a data integrator, I'll be kind of glib in saying it's not my problem what they do with the data and draw the wrong conclusion. Because one could argue, I think there was a publication by Tibershani and Amia last month or something. I think that's the gentleman's name from Stanford. You know, that basically says most of the research published is wrong in general. Even though it's got great scientists on it, we need the data available so people can try to replicate it. So as a data integration person, I may accept the fact that I can't solve whether they do the analysis right, but my hope is if we could begin to build some tools, and so this would be an example of kind of saying, you know, what we're doing here is we're basically saying, go ahead now, this is the tool I was mentioning where I want to build a data set for R. So I said, here's the set I'm interested in. I want to reuse the query, the variables from the query, and then I could go in and I could pick off all the other variables I want to package up in a data frame to send over to R. So what I'd love to see developed would be the people who really know a certain domain of care, for them to build an analysis pipeline that then we could share, that you could plug in to say, okay, you're interested in this type of problem, here, let's get started with this, but really be hand in hand with the data analyst. So it is a blessing and it is a nightmare and a curse. So on one hand, people are like, this is unbelievable. I can now get to something which before was a huge barrier. If you're the statistician, you're like, oh my goodness, how can we let people use this? Because they'll draw the wrong conclusion. But I kind of view it as if we can't figure out how together work on a solution, then nothing's gonna, no one can get the fish.
So it was, I think, Ioannidis that published a paper that said that half of published research is wrong, and that made the news, you know, in every news channel and so forth. And this is for well-structured, you know, NIH-funded, you know, peer-reviewed published research. Can you imagine what's going on if people start doing their own, you know, homegrown, fly-by-night type of analytics with the tool that maybe they don't understand the data, they don't understand the analysis methods and so forth? I think that then it will not be half of it. Maybe it will be 99.9% of it. So the question is, operationally, do you have a beginning of a solution toward warning people about the dangers of drawing, of over-interpreting this preliminary, you know, report results?
We don't completely, but what we do, and we actually discussed this at our oversight meeting actually it was this Wednesday, we were talking about it from the quality improvement standpoint, because in addition to all the research, work is done for quality improvement, right? And so we were talking about when a request comes in for data for quality improvement, we were kind of addressing this issue from the standpoint of we thought hospital quality improvement or clinical quality improvement requests ought to come in and also be routed to the quality improvement analysts so that there's at least a dialogue together to get things pointed in the right direction. So I think it's not something, the quick answer would be it is not something that I can solve by developing a system. It takes people working together to solve, but I don't think restraining people from accessing the data is going to solve the problem. So my bias is maybe wrong, but it is if I can get the data in the hands of the MICU director, and then if he can work with a team, we can get somewhere. If I put up a barrier to say, well, you can't do this until you work with me to understand your data, I'm going to shut down, at least culturally in Kansas City, I'm going to shut down most of my customers. And then I'm going to have built a resource that goes underutilized or never utilized. So I'm erring on the side of I'm at least doing a good faith job of building a resource. I want to build it so it's very responsive, because as you interact with this data, it does face the paradox. On one hand, it's a way to think about it more when you're interacting with it here is think of it as hypothesis generation and exploration. You're just exploring ideas. And that's true that in another sense, you shouldn't do that. You should go in with your preconceived hypothesis, right? You know, so you're not biasing yourself on selection. But I think that the tool shouldn't get in the way of how the person interacts with it. Tom?
So this is outstanding work. And I have two questions. So the cohort identification that you're going through ITV2 is terrific. And I think it's kind of like, you know, with the fishing metaphor, it's like saying there are fish over here in this cove. These fish do indeed exist. It's like, you know, giving someone whispering a secret. But can you talk a little bit about the process that you guys have in place and any chargebacks that might be involved for actually getting, identified or limited data for that particularly identified cohort into the hands of the investigator?
Very good question. And just to your fish in the cove point, there have been some uses for this. That's another observation just to make is, when you're thinking about it from a data and analysis standpoint where you want good specificity and sensitivity, right? You want to have truly good knowledge. There are other uses of this where that is not required at all. So one example was we had a project for Health of the Public class, fourth-year medical student research project, where they wanted to find out who is homeless who comes into the ED. And they didn't need everybody. They didn't need to be perfectly accurate, but they wanted to get some sense of a cohort of who are these people. And their alternative was, I got to go comb through all the ED charts to find this out? No, well, you can look at the flow sheets and find out there are facts about homelessness. And you can incorporate that, and then you can get a small data set that you can begin to do more of a qualitative research with that before you couldn't have accessed. Now, to your chargeback question, the way we work it here is, I think, again, this is an enterprise approach as opposed to a chargeback model. I've taken the approach of this investment is underwritten by the CTSA in-kind support, as well as our clinical informatics coordinator is 100% funded on the CTSA grant. So the types of activities we do for free is we will let you come to our clinic. She will do one-on-one education with you. I will even meet with you for free for an hour or two. When you want to go browse, you get to browse for free. When you want to pull data out, we will pull the data for free because we want to script it so that you use that tool to define your cohort, define the variables you want, and then we drop it to you on a secure server in Excel. We actually want to invest a little bit of our main effort money to make the data set you get be better. So we envision, instead of a CSV, we'd love to, better yet, put it in a REDCap for you. Or better yet, maybe we pivot it into more of a multi-column table that's got the variables the way you want. But today what we're doing is we're not charging for that work. What I have told people, but nobody's taken me up on it really yet, is if you want some data that I don't have, I'd love to get that for you. Would you help me pay for it? So for example, we don't have microbiology results loaded yet. I met with the MIC guy. I'm like, yeah, we don't have it. If I knew other people wanted it, I might think of whether I use my institutional funding support to go after it, or better yet, do you have a grant which you'd like to pay for that? Or if the hospital would like me to incorporate patient satisfaction scores, well, that'd be pretty cool. Hey, can you contribute a little bit of money to the effort? So the approach has been, we're basically, and really the chargeback, where I think you're right though is, for building a REDCap database, we have a chargeback model for that. Either put us percent effort on the grant or we'll charge you by the hour. We've had projects where we work with the College of American Pathology, who's consulting with the hospital on terminology, where one person on our team has helped them understand REDCap, HERON, not REDCap, largely HERON, and also has gone into Clarity and pulled data for them, and we charge back by the hour for that, because they want us to go into the bowels and rip data out. But for using the tool we've built that's user-friendly, the goal is, we sunk the cost. You're just burning electricity to pull it out.
And have you guys started setting anything up for prospective studies, especially clinical trials? Because, all of this, I can see how it could be used for prospective data collection, pulling things out of EMRs and other operational systems. But
that's a really good question. We have not yet in production. One thing we have done is we're doing it's more of a commercial endeavor with a company called New Factor that does immunoglobulin. They're a specialty pharmacy around the country. And we've built a REDCap registry for them that has got all their data, and they're doing more of they're doing an evaluation of kind of physician-reviewed adjudication of is the immunoglobulin being ordered for the right things for a neuropathy. And we envision that as that database matures, they may want a REDCap to store that type of data, but we're not doing anything where the clinical trial data is being derived from the EMR. If you read some of I think there was an IOM report, that's really the wave of the future. We're not doing that yet. But I think the pathway to that, though, the first steps are getting people for quality improvement as well as for registries of patients they want to track to start to use REDCap, and then have us be able to integrate that in this environment. But very good question, but we're not doing it yet for production. Other questions? Wow, and I haven't even had a chance to demo much. Let me think here. We're about out of time. So that's kind of just to give you some high-level overviews of what's in here. Maybe that'd be the best way. You know, demographics are demographics. There again is that research participant feature. You know, one thing we've done is you can't report zip code per HIPAA, but we can tell you how far away you are from the university. That's pretty useful. In many places, we don't have it working everywhere, but one thing you'll notice in our I2B2 build is we tell you the facts and the patients visually, which is really powerful. So that way, you don't even have to run a query to get a feel for how much data there is. This is a really cool feature. I got to show you some of this stuff. So what this is this is diagnosis trees that now have modifiers on them. And what does that mean? What that means that I think is really pretty neat is if I wanted to look at those diabetics, instead of just knowing how many diabetics there are, I can now know how was the diabetes recorded. So let's see if this will work reasonably well. So if I said, let's just count the diabetics, hopefully my system will work right and we'll get back the same number. But you may want to know who said they're a diabetic. So this gets back to your questions or Yin's questions about data quality. I can now go in and say, don't know why it's taking, well again, let me give it 20 seconds. I could go in and say, I'm only interested in which ones have had diabetes recorded as part of their clinic billing encounter, okay? So that's pretty cool, right? So, or I could say, I want to look at something clinically. I'd like to know where has it been recorded in the clinic billing system, but also recorded on their problem list from the EMR perspective. You know, so this gets to the question of data fidelity. One way you might want to go at it is you might want to say, for my type of question, I want the diabetes to have been confirmed multiple ways. I could also use the filter to say it has to occur a certain number of times. So this modifier feature has been one way where we've taken that fact and we've layered attribution on it to where you can triangulate to say, you know, what are the sources of that information, and that way you can kind of break it down that way. We've also brought in a status flag for, is that problem if it's from the EMR resolved? So that's kind of a feature that's kind of neat. Another area that we've focused on that's pretty neat, I think, we saw the social history. This is one we actually asked a question on the I2B2 group about. This family history is kind of a local terminology to EPIC, or it may use IMO after talking to people. But you can look at things like, if we wanted to look at cancer, and we wanted to look at, you know, kidney cancer, that's a good one, prostate cancer. I could look at who's had prostate cancer. This will actually be a good data validity check, right? We could say who's had prostate cancer on their fathers, in their father. Okay? And so it's letting you have that kind of tree as well. Now, you know, some people, now this is my data validity check, and who's had prostate cancer on their mother side of the family? Okay. Will it be 0? Yeah, 6 people. Unbelievable, right? So that gets to your data validity question. How can you have prostate cancer? Obviously, there's data entry errors in EMRs, but you know, it is what it is. So, but you know, that's kind of neat to see that you can start to look at that type of relationship. So we could look at prostate cancer. We could say, you know, who's had prostate cancer in both their father or in one of their both sides of their grandparents. So their parental grandfather and maternal grandfather. Boom. And begin to look at things like that. And that's, again, where there's this feature called modifiers that came out in 1.6 that we're starting to take advantage of, which I think is pretty cool. Another thing, you know, I can be kicked off stage whenever, is we use this same modifier approach for medications. So you can distinguish between, was the order a PRN order? Because if you've ever dealt with EMR data, you may have an order for something, but if it's PRN, you have no idea whether they got it or not. As well as we brought in the MAR, and we brought in all the statuses on the MAR. So sometimes it's documented on the MAR, but the dose was missed versus given. So that's kind of some interesting data we're just beginning to explore. We've got a lot of other rich data. I mean, the UHC data is a gold mine to me because you get all these very interesting details like length of stay. We've recently brought in payer status. So if you wanted to look at the Medicaid population specifically or compare Medicaid versus Medicare, you've got that data side by side. Discharge status can be interesting, who got discharged to a nursing home. The list goes on, but really as we tackle each of these standard data sets, it's really neat. Right now our blog and wiki is offline because somebody accidentally posted patient data on it, so we're going to create this wiki and repost it where we have a public version that's been scrubbed before. But once we get that back up, all the code for how this stuff gets loaded is largely here. And then also we will continue to expose a fair number of the tickets, because that's really what describes what are the thought processes that went through some of the work to try to build out that ETL work. So if I could remember this off the top of my head. So we're working on that antibiotic problem. So this is where Nathan Graham, the lead software engineer on this, is kind of working through all the issues of data analysis. What are we observing in terms of counts? And then he's beginning to use R a little bit to help us do pre-processing. So what we try to do is make the code available, but they're also part of the thought processes that went into it available. Well, I'm out of, am I still, wait a second. When does this end? This ends now, right?
I think that, yeah.
Okay, just want to make sure I'm good on time.
If you want to have a closing statement, and then we can have a final round of questions.
Sure, I'm done. Closing statement is completed. So the closing statement again is, I think, this has been the major area we've probably put our focus in Kansas, has been on data integration to really serve the customer base, And also, again, I also chair the Integrated Data Repository Group for the CTSA this year, and I'm looking to see who else is using these types of tools. We're going to send out a survey on behalf of the CTSA, both to CTSAs, cancer centers, to just make people aware who's doing this type of work and how rich is their data set. And what I would like to see developed is really an honest broker network, first pass, not a technical approach, but just say, I use I2B2, you use Amalga, how many people have you got? And then try to create a network where it may not be technically solvable, but you could at least know who you could ask at another institution to see if there's a prospective trial cohort available. So in closing, I would say pay attention if you're part of the CTSA group, or if you're just interested in general in us trying to get a network going nationally, because I think the huge cost is in building these resources out. And it's silly not to try to nationally get as much mileage as we can.
Well, thank you very much.
All right.
So, any other questions?
Yes?
So in the back-end side, was there any specific reason for choosing Python as a scripting language versus some other object-oriented programming language?
It's because Dan Connolly and I like Python. And I will say this, it's what it really reflects, though, we did do an evaluation of this. A lot of places will use an ETL data manipulation package, like Talend is an open source version, and Pentaho has stuff. We took a look at that stuff, but when we looked at it, and in my enterprise analytics role, I see this a lot. People will choose things like business objects, but if you take a software engineering approach where you want to version control and check things in, they often get in the way of your ability to understand what's actually happening to the data. So we thought using Python as what it gives us is, it gives us a neutral package software that we like to wrap as much vanilla SQL as we like, so we don't use some type of Oracleism to manage our data manipulation. So we think the advantage of it is if anybody else wants to use it, they don't have to pay any money for it. Whereas if we had chosen SAS Enterprise Miner as our ETL process or Microsoft SSIS, we'd be saying to people, gee, we're a Microsoft shop, sorry, you can't use it with your Oracle. And we chose Oracle as our database, though, because that is the enterprise site license for the university. So we wanted to be in alignment with our university IT shop there.